Well, hello everyone again. Thank you for joining and welcome to today's webinar using CBCT-based functional dynamic modeling, where we will be discussing how in vivo model can enhance your orthodontic treatment planning. My name is Anna. I am an application engineer for our in vivo software and platforms. I am joined today by one of our esteemed in vivo enthusiasts and special guest, Dr. Juan-Carlos Quintero. Dr. Quintero holds a dental degree from the University of Pittsburgh, as well as an orthodontic certificate and Master of Science degree in oral biology from the University of California at San Francisco. He maintains an orthodontic practice in South Miami, Florida, and is also the past president of the South Florida Academy of Orthodontists. We will be hearing more from him in just a moment. Before that, in the event that you are unfamiliar with us, we are Osteoid. We are a pioneering 3D imaging software company specializing in the in vivo software, dental services, and cloud platforms. Originally created in 2004 under the company name Anatomage, our in vivo products and services have continued to be the standard in 3D digital dentistry community. Now, as your co-host today, we are excited to dive into our agenda, where we will be discussing what a functional dynamic model is, why we use them in practice, how we use them most effectively, and what the most common applications are. Before we do jump in here, there are a few housekeeping notes as always. We will have everyone muted today during the session. Feel free to jot down any questions that you have in the Q&A box that we do have open. We will save some time at the end to answer any questions that you have, and any that we miss, feel free to send them to info@osteoidinc.com. Now, without further delay, I'm going to go ahead and pass things over to Dr. Quintero, and he'll get us started with our webinar.
Hello, and welcome to the webinar. Thank you for being here. I know that there's a wide range of people here in terms of different doctors and people. Some have more experience and knowledge base on this topic. Some are just starters and newbies. So I want to make sure everybody gets the most of this. So we're going to start with the premise that this is new material for everybody. There's a wide range of general dentists, orthodontists, oral surgeons, pediatric dentists, treatment coordinators. So I hope everybody walks away with good information here. Okay, so let's begin the presentation. So human psychologists have actually studied the field of happiness, and they've been able to quantify and qualify what those important components of happiness depend on. They determine that having purpose in one's life is very important for happiness, to have a reason to exist, doing something purposeful in your life, whatever that may be. Feeling a sense of success at whatever it is that we do, whatever disciplinary that you're in. Feeling that we have control over our future, our life, what we do, in this case, our patients, our practice health, our quality of practice, and our quality of life. And of course, the closer we are to understanding the truth, the more that gives us true happiness. As the philosopher once said, to see is to know. And to know is to understand. And the better we can understand our patients, our cases, the more we can help our patients. And ultimately, that's why we are here. René Descartes was a very important philosopher during the 1600s, known as the Enlightenment period. And he postulated the Cartesian theory, which stated, I think, therefore I am. What that really means is the only thing we can really know for sure that we exist is because we're able to think. And because of that, we have reason. And he said, if you would be a real seeker after truth, it is necessary that at least once in your life, you doubt as far as possible all things. So that's what we do as scientists. So this is the way that dentistry, specifically orthodontics, has evolved through imaging in 2D and in models to have a better understanding of that truth. Things have evolved with technology. This is a traditional 2D image, and we're going to talk about the topic of dose. So a panorex is equivalent to about 25 microsieverts of radiation exposure. Okay, a bite wing is about 5. A lateral ceph is about 5. Okay, so a panorex offers great clarity but low accuracy. This is a warped, distorted image. We do not exist as a flat 2D world. We cannot see depth. We cannot see that third dimension, but it's a very clear image. This is a low dose CBCT that is equivalent to about 11 microsieverts. Okay, now I want to be very clear that not all CBCT manufacturers, machines, and settings were created equal. Okay, this in particular is the machine that we use in our practice. This is from iCat. It's the iCat Flex, and it has the ability to modify the field of view, the exposure time, and the dose delivery. In this particular case, it's an extended field of view on the lowest possible dose that you can have. That's equivalent to 11 microsieverts of radiation on a patient. So you can see that it's significantly lower than a pano, a little more than half, a little less than half. So we always need to understand when it comes to imaging, especially when there's radiation involved, what are the risks? And so there is a rule called ALARA, which stands for as low as reasonably achievable. More important than that is the new principle of ALADA, which stands for as low as diagnostically achievable. Okay, so we have this little table which just shows the comparative and relative values of 2D, say pan-ceph, versus 3D, a low dose CBCT. So a ceph, a pan and ceph, their diagnostic score is low relatively because there's distortion. The radiation is higher than a CBCT low dose at appropriate settings. A CBCT, the diagnostic score at an incredibly low dose is also low because the lower the exposure, the lower the radiation, the lower the resolution. So you are going to get degradation of image quality. However, the radiation is relatively lower than its 2D counterpart. What we're going to be talking about today, functional dynamic modeling, is interchangeable with many things. Okay, we're going to, in vivo model is the product name that Osteoid delivers to what we're going to be talking about today. Osteoid was previously known as Anatomage, and the product used to be called Anatomodel. Now the company is Osteoid, the product is called in vivo model. But there are different synonyms which may kind of escape today. I may refer to Anatomodel, I'm still getting used to it. It's in vivo model. It's also known as surface mapping or segmentation, and that will become clearer as we go. So the ALADA score for an in vivo model is higher than the score of a cone beam by itself or a 2D-dimensional series for diagnostic orthodontic purposes. I just want to show you a case just to tease everybody a little bit. Okay, so this is a CBCT taken at low dose, 4.9 seconds of exposure. Radiation level is very, very minimal. It's called the QS plus settings on the iCat Flex. For those who have it, know what I'm talking about. So you can see here that the image is, again, it's accurate, but it's not quite clear. So there's not really noise there, but there's a lot of lack of clarity. Okay, what the in vivo model product is taking this data set and performing a process called segmentation and surface mapping of all the elements, including the bone, the teeth, the hard tissues, the nerves, and you get a product known as the in vivo model, okay? This is, for us, our all-inclusive single diagnostic file in our practice that we use, just one file. We virtualize the patient, and everything is layered. So when I refer to the topic or the idea of segmentation, the skin has been properly laid upon the face. You can turn it up, dim it down. Okay, then you have segmentation of the bone, the maxilla, the teeth, the roots. Okay, now hopefully what will become standard. And let me just turn off the nerve. So I can turn off any of these elements. So some of the great advantages here are, why is it functional? Well, number one, you can move it. Secondly, you can interact with the data. So that means that we can increase the opacity, decrease the opacity. Thirdly, we can color certain elements, and that is great for presentations and understanding. And we're going to talk about that further down the road. It's also functional because of our ability to move teeth, right? Or move elements, right? So you can take this tooth here, you can extract it, you can flip it upside down, right? You can do many things with it. So not just are there dental functional movements which are allowed, but skeletal as well. For instance, for rapid palatal expansion on children or on adults using more surgical interventions, right? We can simulate these skeletal movements. So they have something called an in vivo model is formed on the premise of something called the parent-child kind of concept, right? So the parent is the bone, the jaw, and the teeth are the child or the children. Okay, so it becomes very functional in the sense of being able to simulate treatments and predict, kind of like what we used to call in 2D orthodontics, VTOs, virtual treatment outcomes, right? This is one step up, or maybe 1,000 steps up from that. Okay, so this is what the in vivo model product is exactly what you're seeing. Okay, it's a 3D functional dynamic model that you can use to really see, and to see is to know, and to know is to understand, right? On top of this model, besides this model, what the company does, it will segment the nerves, the inferior alveolar nerves, may not be too relevant for orthodontic purposes, particularly in a case such as this, like mixed dentition, but it may become more relevant later on with adult patients that need implants or third molar extractions and so forth, okay? Another advantage of getting an in vivo model, and this I think it would be an add-on, but it's well worth it. It's the 3-dimensional cephalometric tracing, okay? So they will trace the ceph for you, and the software has many different types of analysis in their library. My particular analysis of choice is the Bjork analysis. I also have a WITS analysis for those who know that. So you can certainly customize, mix and match different analyses with different values. So you could have a Bjork, kind of like I do with a WITS, and you can add Steiner, Sassoon, whatever it is you want. You'll also get from the in vivo model package some preset images. So for instance, for those who still like the 2D world, a lot of our colleagues still want to see panos, and that's fine. So an auto model will create a pano. By the way, you can also do this yourself without the in vivo model product, but by default, it comes with the package, so you don't have to extract the pano on your own. It will come with a 2D image of the ceph. It will come with this display of the models. It will come with an airway and a face. And these kind of series of extras, if you will, are very customizable, right? So in particular, like for my cases, they know to color primary teeth a certain way. You can see here, you're wondering way in the back, okay, why that tooth is red. Well, it's clearly that's just removed. So you can see how I'm interacting with the data, right? And dissecting essentially the patient. So you can see how these are supersized, ectopic, permanent maxillary lateral incisors. Where are they? You can see this patient has supernumerary primary incisors, okay? So you can really start to see. And we're going to talk about a particular use of this technology for identifying supernumerary teeth, which are the real ones, which are the culprits, et cetera. One of the things that I get on our Onata models, and I believe that this is not an extra cost, but and this is an evolution of the in vivo model. It wasn't always like this, but we've been able to now make it standard that I want the condyles, I want the joints, and I want the palate, nasal floor with the maxillary suture present so that I can simulate some of these movements, right? So this is very important because we, in our office, depending on your philosophy, but in our office, we do a lot of palatal expansion. Maybe I should put this baby molar back where it belongs, okay? In the good periodontal housing. Okay. So, and speaking of periodontal housing, right? There's, of course, a lot of systems now that will do digital models, right? And they have orthodontic capabilities to move teeth, like many of the aligner companies, right? Which have come a long way. But in those digital formats, teeth know no boundaries. They don't have osseous boundaries, right? So one of the great advantages of doing virtual simulations here is the ability to understand the confines of those osseous borders, okay? So there are many, many advantages to the Onata model. I just wanted to show you an example of what that Onata model, I'm sorry, there I go again, in vivo model is, all right? So let's talk about how this is done from an engineering perspective, just briefly, okay? So this is the raw data, the volume rendering, the CBCT. This is what you get when you push that button and the in vivo software or whatever software comes with whatever cone beam machine you have will reconstruct all the different files of DICOM into a 3D rendering, okay? So this is it. So when you submit your cone beam raw data to Osteoid, the segmentation process is very proprietary, by the way, and it's very advanced. So they'll segment an individual element. In this case, looks like it's a molar, all right? And then they'll do the surface mapping, all right? And they'll do this with all the elements. So think of deconstructing the puzzle, cleaning up the pieces, making them nice and shiny and smooth, and putting that puzzle back together, okay? Then they'll add all the teeth. Then they'll add the bones. And this is what you get. This is our one and only diagnostic file in our patients, in our practice for our patients. So you can do videos. This is the Airway. So for any patient who has an airway, it would be nice to see the airway dimensions and how orthodontic treatment or how the airways may impact your orthodontic treatment plan. For better or for worse, those airways will be affected one way or the other, okay? And we're going to talk about airways down the road. I forgot to mention, this is the first lecture of a series of lectures that I will be giving in conjunction with Osteoid, and I've created kind of a curriculum. So today's session is really kind of an overview of an Onata model. For those who are interested in more specific topics, stay tuned. Okay, so segmentation. This is just a pretty artistic rendering of an Onata model. You can do all kinds of cool images here. But what are some of the advantages of functional dynamic modeling? A greater approximation and understanding of that anatomic truth. When you go from the cone beam raw data volume rendering over to an Onata model, especially if you're talking about low dose, which is what we want to be doing with children in particular, and just by the nature of being in orthodontics, we are seeing lots of children. So we do have an obligation to keep the radiation as low as possible. And as I've said, that may come at the expense of image clarity. So the great advantage of the in vivo model then is to crystallize that data. We're able to see roots, root development, root size, something that something that is missing in a lot of the other kind of virtual orthodontic systems. Aligner companies, they're doing great, but we all know orthodontics is really happening at the root level. We're able to see, again, those confines of bone, the maxilla, the mandible, the condyles, the sutures, the alveolar housing, the periodontal housing. We're able to see airways. And we'll have a separate lecture on airways, several. We're able to see that maxillary suture, even the zygomatic suture. The joints, for any patient who has joints, that is very relative to what we're doing. So we're talking about faces, we're talking about occlusion, talking about airways, we're talking about joints. So we want to be more than just tooth straighteners. We want to think about the patient as a whole with all of these different compartments. And this technology is not only allowing us, but forcing us to view our patients better and more holistically. We're able to perform virtual movements. Anatomy is segmented, so we can move segments of the parent-child relationship, the parent or the child. We can color these teeth. We can elements, right? We can color the elements. We can delete the elements. We can move the elements. We understand this is all done from a parent-child relationship. One of the advantages in treatment planning with a tool like this is we can better think about our biomechanical designs. We can understand the concept of anchorage and reciprocal movements, incorporate TADs. There will be a separate course on just TADs, orthodontic surgery, right? We can do simulations of how the face, the soft tissue will respond. And what's really interesting is how do these mechanical movements affect the face, affect the airways, affect the joints? So it allows us to, little by little, become better providers, better healthcare practitioners with this technology. Never mind the benefits of teaching what I'm doing here today. It's a very beautiful, image-rich system. So it allows to teach others, study groups, dental study clubs, but my favorite is teaching patients and teaching oneself. So very market-friendly. Okay, so let's look at these two. What is the advantage? Again, the system, the difference between a basic volume rendering that you have here on the left, and I took the exact same case, and let's compare with an in vivo model. Here it says an auto model. Need to change that. Okay, in vivo model, all right? So see for yourself. This is the dynamic value of segmentation and surface mapping. We are allowed to move these teeth. Okay, we have a very hairy, impacted upper right canine. Okay, if one possible solution is extraction of a premolar, but then we have to think about biomechanics and vectors. How do we move that canine down without bumping into the root and resorbing the root of the lateral incisors, right? So I can simulate this expansion that we're going to do. Let's look at this again. I can simulate the expansion. I can color the teeth. I can educate, okay, that green tooth is going. I put a virtual TAD up in the upper right quadrant. I don't know if you can see it, right? So this really helps to give me confidence in the treatment plan. And confidence is everything. The patient can see the treatment plan. They can see the confidence in the doctor. They say, okay, I understand now, right? So these things are not designed for the same day start office. In our particular office, and again, we'll have a separate session on the business, how to incorporate the records flow. It takes a little time. It takes a few days to get this back. It gives you an opportunity to think about the case a little clearly, calmly, really set up that treatment conference presentation. Here's another example. Volume rendering. We'll go through this a little faster. Same thing, impacted canines. For those who are just getting started with this technology and want to, impacted canines is probably the first reason people would want to do this, to really visualize and to be able to move. Okay, now on a PanRx, you can imagine, is that impacted canine buccal or lingual, right? Yeah, there's the slob rule and all that kind of stuff. But keep in mind that could be higher radiation depending on the settings, right? So why would you not want to do this if it gives you better diagnostic information at a lower radiation cost? And if you could do an in vivo model with segmentation, it's kind of a no-brainer. Here's another one that's very useful. Supernumerary teeth. With supernumerary teeth, it's a little trickier to see on the volume rendering. You have to really know how to use software to go through slices and stuff. But with the in vivo model, we're able to color them, we're able to see them. You want to make good friends with your oral surgeon, send them a file or an image like this. They will be so thankful that they know in advance, pre-surgical image-guided navigation, to know exactly where these supernumerary teeth are. Where are those third molars relative to the root, right? So it really leads to more conservative surgical procedures and better management of risk. Okay, I love the capturing of sutures. Again, what we do every day in our office is orthodontics and dental facial orthopedics, the parent-child relationship, right? So for those of you who see young children, you have an opportunity to really perform growth modification at a true skeletal level. And it's probably the best orthopedic manipulation that we can do for our young patients is by use of that skeletal palatal suture. And remember, when you expand the palate, which is the roof of the mouth, you're also expanding the nasal flora. How does that help for breathing? How does that help with the face of the growth of the face, for crowding, and so on and so forth, right? So for us, having that palatal suture is critical and instrumental to our treatment philosophy and our treatment planning. So again, you can only do this through the in vivo model, surface mapping, segmentation product. Okay. What about condyles? Okay. At the very primitive birth of the Anata model, so to speak, we didn't have the engineers weren't giving us condyles or sutures simply because they didn't know how valuable they could be for us. So it's very possible. The data is there. It's just a matter of applying the same software that they use, the segmentation, right? So the condyles are very important because we know that the mandible grows through the condyle. These are the growth centers of the face. Wouldn't that be critical in diagnostic and treatment planning? Okay, now let's talk about radiation a little bit. And I'm going to use the example of the iCat Flex in particular. There's many, I'm sure many good companies that are following, but this is the machine that I'm familiar with, that I studied the radiation levels, and this is why I chose this machine. Okay, so one of the advantages of the iCat Flex is the ability to really turn up or dial down the radiation dose depending on the case, right? So remember, higher radiation results in higher resolution, higher image quality. Lower radiation, lower image quality, lower dose, lower resolution, but safer, right? So is there a difference in the requirements for in vivo model? Do we need a high dose scan, low dose scan to get in vivo model? Right? So this is where it gets really interesting, okay? So let's quickly compare, let's quickly compare the image quality on these three different scans. So to the left, you have a very high dose scan. It might be very good for an adult patient that needs a total joint replacement, and you really want to see those condyles, or if there's distinct pathology that you're aware of. Okay, this is a 15-second microsievert dose, which is probably in the range of 70 to 80 microsieverts. Okay, this is a 9-second. This is prior to the iCat Flex. This was a lower radiation exposure, And I'm sorry, this is probably closer to 120. Okay, so 9 seconds is 85. So you can see there's not much of a difference in the diagnostic quality of these volume renderings, right? So why would you want to do a 27-second scan when you can do a 9-second scan at lower dose, right? It's diagnostic enough, okay? Now let's compare when the iCat Flex came out. I was really excited about this because we see children, right? So iCat Flex iCat was able to engineer low dose, okay, at 4.8 seconds. You have to use the QS plus settings at 11 microsieverts of exposure compared to the 85 microsieverts at 9 seconds, okay? Clearly, there's a difference in clarity, right? Obviously, there is a sacrifice in the image quality, right? Now, these dose levels, it's very important to understand the scientific evidence behind these numbers. I'm not just throwing numbers out. These are values that have been studied, and this information, here's the reference. It's Ludlow, who studies, he's probably the premier researcher on dental radiation at UNC. So he measured these qualities. So these qualities are supported by the research. Okay. All right. So, ladies and gentlemen, okay, here's the Anata model, in vivo model, from that 11 microsievert cone beam. Keep in mind, a Panorex is more than double of that. So you can see here the great advantage in clarity, movement, sutures, airways, design, treatment planning. So for those of you not getting into cone beam yet, you can no longer use the argument of radiation to not do it. You can no longer use the argument of clarity to not do it. It would be, let's face it, strictly a business decision. Which, by the way, if you want to improve your business and make more money, if you're into that kind of thing, I don't know, that's more of a reason to do it. But we'll get to that later in another presentation. Okay, this was just an example of, is the image diagnostic enough? Is the at 11 microsieverts diagnostic enough for a radiologist to interpret it? So I did a test, and I sent this to Beam Readers, which is the radiology group that I use on some of my cases, not all of them, on some of them, select them. And they didn't know the microsieverts, they didn't know the exposure time. Although David Hatcher's a very smart guy, he probably figured it out. The point of this slide is to demonstrate that it is, from a pathology radiologist perspective, this is more than adequate. It's sufficient. So this has now become our standard diagnostic tool in our practice. This is Orthodontics 2023. And needless to say, this volume, we can dissect it into the 3 planes of space. So great for airway analysis, sinuses, jaw asymmetries, adenoid tissue, a lot more than just dental stuff, right? Soft tissue, airways, okay? Now we can start to build all these pieces of information in our mind to come up with solutions for patients that are better, okay? In vivo software has something called a quick slice explorer tool, and you don't need an in vivo model for this, right? You just need the in vivo software. But I present this as a macroscopic and microscopic at once. So you're able to see the forest, and you're also able to see the trees and the roots of the trees. Pardon the pun. Never really thought about that, but it's true. So you're able to go in and take a virtual 2-dimensional periapical in any part of the volume from any perspective. Pretty incredible. Okay, the great advantage of the in vivo model is its diagnostic value. Okay, so let's take a look at a case like this. This was one of the first cases, right? Impacted canines, bilateral, all right? How much damage is there? How do we bring those canines down? Are they palatal? Are they lingual? Are they facial, right? And there was a study that showed when you have bilateral maxillary impacted permanent canines, 90% of the time, they are both on the palatal or both on the lingual, okay? So how do you generate a treatment plan without knowing that buccal dimension, okay? Well, this particular case, interestingly, this was many years ago, it showed that one was on the facial, the other was on the palatal. How interesting, okay? So we were able to better treatment plan that case. These are just different images of in vivo models with patients who had a variety of impacted canines. The freaky threes, I call them, right? For those of you who understand the Palmer nomenclature system, right? The freaky threes, right? These impacted canines can be some of the most difficult and riskiest orthodontic treatment plans that we know of, right? There's all kinds of risks that patients have to accept, right? So the better armed we are with that information, the better we can manage that risk and make sure that the patients clearly understand that risk. Nerves, this is very important for the adult patients who never had their third molars removed. In our office, we are big fans of early removal or early enucleation of third molars when you think about the risks of a fully impacted, fully developed third molar in the relationship to the nerve. There's a lot of unknowns on a 2D Panorex. So that's why the oral surgeons make you sign a boilerplate informed consent about a nerve injury. But there are risks and then there are risks, right? So how nice is it to be able to really quantify that risk? So in a case like this, of course, you may want to leave that third molar alone. So we'll use this slide, for example, to educate our patients why it's important to have their third molars removed before a certain age, before the root apexification. And so again, this visual really helps patients understand, okay? For those of you involved in orthodontic surgery, that field has also been revolutionized through computerized surgical treatment planning. So we do a lot of, we're involved in a lot of orthodontic surgery in our office. So our surgeon takes our data from the cone beam that we provide and will send it to one of many companies to perform their virtual computerized treatment planning in advance of the surgery, from which they can then make surgical guides, surgical splints. Three-dimensional cephalometrics, much better than 2D data, right? So they average out a lot of those critical landmarks. In fact, I'm going to put a little plug for Osteoid. They have recently come out with the first and only automated cephalometric landmark identification process. All right. So that's really reducing the human error and time and effort in creating three-dimensional analysis, right? So it's part of their AI system, which is being automated. I don't know if that's out for release yet. Pardon me, I don't even know if I was supposed to talk about that, but it's very exciting. The value of superimposition. How do we learn orthodontics? Well, we learn orthodontics from studying data sets and from understanding growth and from understanding before and after treatment results, right? So there's something called superimposition. Now, of course, the value of superimposition is going to be much greater using 3D data than 2D data, right? So this is critical for instance, if you're trying to monitor cessation of skeletal growth on a patient who needs implants, right? So let's say missing lateral incisors, right? One of the worst things that you can do is put lateral incisor implants too early because the jaws may not be finished growing when they're not finished growing vertically, right? So it's very important when you're trying to decide the best timing for dental implants to have a better grasp of cessation of jaw growth. Airway analysis, that is such a big topic that's probably going to require maybe 2 or 3 different course sessions on airway. So we're going to get into that. MPR, just so you understand what that means multiplanar reconstruction. These are just the two-dimensional views. So we have the coronal, we have the axial, we have the sagittal, and of course we can scroll through the data in and out. So we can be better at what we do, right? We can be better at what we do. Clearly, this is going to elevate your relationships and your understanding of airways and relationships with the ENTs. So you'll be able to do more for the patients because you can see more. So a lot of this is not really necessary to get the in vivo model, just having the cone beam in general. So you'll be able to do more for your patients because you have more information. So a lot of times in our practices, from a business perspective, we may be underperforming because we are under delivering and underserving our patients, right? So as we enhance that information, we're able to do more and do better in every regard. Okay. How about joints? Are they not a critical part of what we do if we want to be more than just tooth straighteners, right? This is the nature of jaw mechanics is functional and dynamic, right? Our joints are designed to move our faces, to bite, to chew, to eat. It's also part of the anatomy that ages with time. So it's very important to have a baseline understanding of joint health on anybody who has a joint, okay? And I think you understand what I'm trying to say. Okay, how about the identification of pathology, right? A lot of times, incidental pathology comes up in the absence of symptoms, right? We will be the first to discover certain lesions. And you can't do this with the same day start concept, right? So you pick up these problems on patients when you really take your time and dissect the data. So we're able to see the transverse. So in this particular case, if you just look at the models, like study models, plaster models, does this patient have a transverse discrepancy? No. Does this patient have a crossbite? No. However, when we scroll through the coronal slices and we study the emergence of the first molars in this case, you could see how they're lingually tipped, right? So if we were to upright those lower first molars, guess what? We would then be in a crossbite. So I've said this before at the AO session in public, we need to remove the word crossbite from our orthodontic and dental vocabulary. We need to think in terms of transverse relationships, something we can only really appreciate in the coronal section. This is what we call the teepee effect, right? Like an Indian teepee. Those red lines should be parallel, not convergent, okay? And this is the next step. This is now how we can really, when we get the in vivo model on a case like that, you'd be surprised how many transverse problems will be unmasked and revealed, and that will change the way you look at the case, possibly the treatment plan. What about torque on patients? What about angulation, right? That's so important. I mean, we talk about supplementary numbers and so forth, but what really matters, in my opinion, is how the teeth emerge from the alveolar process, right? So we can do this on every single tooth, right? With certain in vivo features. The sutures, we talked about the value of the sutures. We do a lot of expansion, as I said, with young adults, older adults. We're doing a lot of RPEs, right? So we measure, are we truly getting skeletal expansion? Or are we getting, how much dental expansion are we getting? This is one of the reasons in our practice, we favor rapid palatal expanders on children, because studies have shown that you get more of a skeletal stable effect, even with airways, versus say an upper removable expander like a Schwartz, right? So we like to study that. Is this really happening, right? We're doing a lot of MARPE. For those who aren't familiar with it, stands for mini implant assisted rapid palatal expansion. Okay, so question everything. Like Descartes said, question everything. Is this stuff for real? Is this really happening? Well, to see is to know. we wanted to study. So we do this on all of our patients before we remove the MARPI or the RP, right? Are we truly getting skeletal expansion? And then for older patients who are more severe, we still do lots of SARPI, surgically assisted rapid palatal expansion, right? So you can clearly see the sutural separations, right? With the in vivo model comes the cephalometric analysis, which I didn't really show you, but in the software, once you have this segmented, right, this would be part of the parent segmentation. It has features in there where you can play around with orthodontic movements and simulations, and you see the soft tissue change, and you see the soft tissue cephalometric values change to better normalize them. We talked about the great value of segmentation for patients that have ectopic teeth or supernumerary teeth, right? So really what it comes down to is on these cases, would you rather know, or would you rather guess? Supernumeraries. For those music lovers, Dire Straits, Mark Knopfler, he had a song, it was in the album Telegraph Road. I can't remember the name of the song, it escapes me. But he said, two men said they're Jesus. One of them must be wrong, right? So which is the real McCoy, which is the imposter, right? So what we do is through the in vivo model, segment the teeth, we virtually move them, extract them, and analyze. And we can rotate and look at the morphology, because it's important to know which one is going to be extracted, which one are we going to keep. We're able to many times merge and stitch intraoral scanning, whether it be Trios or iTero, whatever machine you have, with the cone beam. So we'll send this to osteoid as well. And so the great advantage is the detail of the occlusion. So typically we don't do this, but it's sometimes necessary, because one of the disadvantages of cone beam is the amount of noise and artifacts that are present on metal restorations, as you all know, right? So many of our adult patients that require interdisciplinary care, we want complete data. So we can send them the two data sets, the DICOM cone beam and the intraoral STL, and they will stitch, and you can see the great difference there. Okay. So I think we're getting pretty close to our time. I think now would be a really good time to, this just shows you a simulation, a treatment plan, but I think now would be a good time for questions and answers. If I have answers, I don't know. But Anna, I'll give it back to you.
Thank you, Dr. Quintero. It looks like a couple have come through, so we can tackle a few of them. First question I can see here is actually two-part. Says, and I think you may have covered this before as well. It says, do you share the in vivo models with the patients, and what kind of patient feedback do you normally get when you do so?
Definitely. So our practice form is we do a treatment conference on all the patients, right? We like to take our time and study the case. So that is probably the single most rewarding factor of the in vivo model, is to be able to show the patients. The patients are in awe. It's interesting, when you show a patient in a Panorex, they don't really understand it. It's hard for the mind to put that together geometrically because it's off. But when you show them a 3D volume and then you show them an Anata model, they get it. They say a word is worth 1,000. A picture is worth 1,000 words. I think would say an in vivo model is probably worth 10 trillion words. So yes, definitely we share the in vivo model with the patient at the treatment conference. What was the second part of your question?
I think you actually got both of them. Do we share them and the feedback that you get?
Oh, yeah. So patients love it. Yeah, for sure.
Looks like another one that's come in is that you already may have answered. What kinds of cases need an in vivo model or a functional dynamic model?
Well, not to sound brass, but any patient, any case that you really want to do the best for them. I mean, why wouldn't you? Because you have less radiation exposure, you have more diagnostic value, you have increased clarity in your diagnosis and treatment plan. And the number one problem in orthodontic treatment And the number one reason cases take so long when they're supposed to take 2 years, they end up taking 3 years, 4 years, 5 years, and more, right? There's many reasons that can happen, but certainly the number one is wrong diagnosis and treatment plan, right? So we want to do this with every patient, at least for us. Now, I'm not saying for those who haven't done this to go ahead and start setting 100%. The way I started years ago when this came up was I picked and choose my cases, right? I picked and choose which cases would have cone beam. Those were typically impacted canines, right? And I saw how that just evolved into better treatment for those patients. And I started thinking, wow, these more severe, difficult cases are actually getting better cases than the ones that seem so quote unquote simple. So, you know, it's a spectrum. We started with a few, now we're doing each and every case.
Perfect, thank you. There is one that comes in here that asks, how much work is it to do the diagnostic simulations with those in vivo models? And can we create several different simulations?
Great question. How much work is it? Well, it really depends on your experience with it, right? Once you get comfortable with moving teeth and so forth, it's very easy to do. It's going to take some practice with the software. And the simulations done are, you know, that depends on your knowledge base, right? It's like some of the aligner softwares. I mean, you know, I always say you can flip a tooth upside down if you wanted to, right? But in biology, that's really not going to happen. So that's why having the bone parameters present is so important to have realistic simulations.
Mm-hmm.
Yeah. What was the second part of that question?
You can, I can help answer that. You definitely can program to have several different simulations. It's basically a drop down within that model tab that you can select each one from. So you can have different, you know, treatment paths that you may be considering for sure.
Yeah, so we oftentimes do that. An orthodontic option, a non-surgical option, a lower incisor extraction option. So, you know, so many times it's important to really study the different options and present them to the patient. It's our duty to present an ideal, optimal treatment plan, but then also educate them about alternatives, right? And what they're missing, right? So it really helps having those different simulations sometimes for patients to make better decisions. And after 23 years in practice, I'll tell you that the best patients are well-informed patients. The better informed they are, the better experience is going to be for everybody.
Absolutely. One additional question, there's a lot of them coming in, so I apologize, we'll get to as many as we can. Can you superimpose a true 3D face scan to the CBCT for a more accurate face? So instead of that traditional frontal photo?
So no, there are other systems that do a better job. Given the ease of how they do it, right? So they get fiducials on the soft tissue, capture of the cone beam, and then you submit a photograph that you take in your record in your typical diagnostic orthodontic photos. But there's probably going to be a little bit of error matching those fiducials because it all depends on how you take the picture, the lips, the posture, the head position, right? So I think there's still better systems out there. I know Dr. Bill Harrell, shout out to him. Yeah, he's committed most of his orthodontic practice, life, and studies on developing soft tissue superimposition with cone beams and having even a better all-inclusive 3D file of the patient.
Absolutely. And I know with our specific services, we do accept what's called an OBJ file format with a .bmp, which is the coloration of that file format. So I know they come in lots of different file types, not to get too technical. So if you do have additional questions on the ones that you have and what's acceptable, feel free to reach us. Let me get to the next one here. I think we have already answered one of those. One of them is, how can I get the software and learn all the features, which I'm happy to answer if you'd like me to, Dr. Quintero.
Yes, you'll answer them much better than I will.
You can simply reach out to us. We'll help go over the different options as far as the in vivo software goes, as well as the service in vivo model, how to get started there. Depending on which options you're looking to incorporate into your in vivo model, in terms of costs there, just to go over that a bit, it can vary. However, typical in vivo model, similar to what we're seeing with Dr. Quintero, which includes the 3D tracing digital study model, and then our 3D face photo wrapping is 110. And then we do offer volume discounts, so please feel free when you do contact us. We'll answer those additional questions depending on, your volume, what you're looking to incorporate, and how to get started with the base software as well.
Anna, can I ask a question for the audience?
Absolutely.
Are you guys offering any kind of promotion, like a freebie, like first time, if they want to just try it out? Anything that you guys are going to make it easier for new users?
That is an excellent question. Those who are in attendance today for our meeting will go ahead and provide that first case at a no charge. So we will go ahead and get you started, create your account, run you through case specifics. You'll meet with our team so we can make sure that we're creating the specific model that you would like us to create, as well as if there's a tracing involved. So that will go out after this via email to let you know that you do have access to that. If you're ready to get started, we'll comp the first case for you. And anybody who did happen to miss joining due to time zone issues, we know we're hitting a global space here. That's still applicable. Yes, absolutely. Let me see if I can grab one more. One more is on the clinical side. How do you measure or track the nerve on CBCT?
So we don't do that. That's a service that's offered to us from when we get the in vivo model product. However, you don't need to have the in vivo model product to track the nerve. So there's a nerve tracking feature that allows you to track the nerve yourself.
Yep, that is a part of the in vivo software through one of the tabs that is associated with it called Art Section, that allows you to isolate it, and then you can see it in the subsequent portions of the software. And we're happy to show you that if you'd like to take a look or need a refresher on it. Same thing. Contact us, and we'll make sure to get you up to speed. But it looks like we have just a minute left here, so I am going to go ahead and wrap us up. I will send out answers to any of the questions that we didn't get to, but again, please feel free to send any over that come throughout the day if you're just starting your day to info@osteoidinc.com. I do want to thank everyone again for joining us. We look forward to seeing you all again in the next webinar. Look out for the email following with a link to this recording, as well as answers to any questions we have missed. So thank you, everyone. I'm going to go ahead and close down for the day. And thank you, Dr. Quintero, for joining us.
Thank you. My pleasure.